Welcome to this short video on personality disorder. This is the third video in the series, and in this session, we're going to focus on understanding EUPD, which is emotionally unstable personality disorder, and that's the same as BPD, which is borderline personality disorder. I'm Dr. Krisha Patel, and I'm the mental health lead for the company. This session is interactive. Think back to the patients you have met with emotionally unstable personality disorder. So number one, I want you to list the traits and features of EUPD. If you're not sure about the traits and features, then just describe how they've presented to you in the past. And the second question, what do you feel or think about patients with emotionally unstable personality disorder? Write down your thoughts or spend a few minutes discussing these if you're working in small groups. So let's start with the first question, which was to list the traits and features of emotionally unstable personality disorder. And I said, if you don't know the traits and features, then just describe how they've presented to you in the past. I haven't listed all the features of EUPD, but on this slide, I've listed the main ones, which are self-harm, feelings of emptiness, intense and unstable relationships, mood instability, impulsivity, excessive avoidance of abandonment, and emotional intensity. You don't need to have all these traits to make the diagnosis of EUPD. And the diagnosis is based on in-depth history, looking into the past psychiatric history, the current symptoms, the self-harm history, relationship history, personal and childhood history, etc. There's often a history of self-harm or other self-destructive behaviours, and these are usually seen in times of distress, often related to the mood instability and impulsivity. And patients can be very sensitive to abandonment in relationships. And this could be related to their personal experiences of childhood abuse, neglect, parental abandonment, adverse childhood experiences, or attachment difficulties. So the second question was, what do you feel or think about patients with EUPD when you assess them? And I wanted you to be as honest as possible about this. So patients with emotionally unstable personality disorder often evoke strong emotions in staff who are assessing them. I've heard some staff say that they think the patient's being manipulative or attention-seeking when they make threats to end their life. I've heard some staff say that the pain is all psychological. Why do they need to be in A&E? They're time wasting. I've heard healthcare practitioners say that they don't understand what their role is. They say things like, I'm not going to be able to sort out a lifelong personality disorder in the next 30 minutes. And I often think these thoughts come down to the healthcare practitioner's inexperience, and these anxieties are often related to a lack of knowledge about emotionally unstable personality disorder. So if you are a healthcare practitioner and you have anxiety about assessing people with personality disorder, the best thing you can do is to learn about personality disorder. And often the anxiety comes from not understanding our role when we see someone in distress or in crisis. But our role is as simple as just taking the time to listen, acknowledging that person's distress as something that is real, understanding that psychological pain is real, and offering the patient some validation. Validation is something that can really help patients with emotionally unstable personality disorder, and it's a key strategy in the treatment of patients with EUPD. Validation is not the approval of the behaviour, so if a patient's taken an overdose, validation is not giving approval of taking of the overdose. Validation is acknowledging that the patient is in so much distress, they couldn't tolerate life anymore at that moment, and they felt the need to take an overdose. As the healthcare practitioner, you might not truly understand why they chose to take an overdose of 5 paracetamol in response to a trigger like a breakup. The thing we can try to understand is that the patient is in distress, and that's their learned way of coping. And in psychological terms, we usually call that a maladaptive coping strategy. So they might not have learned or know a better way of coping in distress. And that could be due to their past experiences, their traumatic upbringing, or for other reasons. All we really need to understand is that the patient in front of us is distressed and is in need of care. They're seeking care and support now. And those threats to self-harm are just the patient's way of communicating that distress to us. So patients with emotionally unstable personality usually have difficulty managing their emotions. And in psychological terms, we'll usually call that emotional dysregulation, which is not a diagnosis in itself. It literally just means difficulty managing emotions. Emotions can become heightened very quickly and then take a very long time to come back down to baseline. Here is a diagram of what I mean. So the blue line represents someone who is able to regulate their emotions. So after hearing some bad news, which we'll call a trigger, someone might feel stressed, angry, upset, but their emotions will come back down to baseline after a period of time. In patients with emotionally unstable personality disorder, a similar trigger can lead to heightened emotions much more quickly, and it often takes a lot longer to come back down to baseline. And if you can imagine a second trigger happening here, you can see how quickly things can escalate. And one thing that many patients with emotionally unstable personality disorder may experience is something called a crisis. So things can escalate into a crisis point here, where there's intense emotions and real difficulty managing those emotions. So a crisis is a time of heightened emotion and distress, and that can be really difficult and intolerable for the patient. And when you assess someone's mental state here during a crisis, it can seem very different to when you assess their mental state here when their emotions are back to baseline. And the time spent in crisis can vary from hours to days. And this is the nature of emotionally unstable personality disorder. And if you can also imagine, during a crisis and during this time of heightened emotional state, it's easier for the patient who has the tendency to act impulsively and self-harm, if that's their maladaptive coping strategy. So this is why we should always explore self-harm and suicide risk when someone presents to you in crisis or in distress, because it can be a time when the suicide risk is acutely raised. And in some cases, if it's felt that the suicide risk is so high at that time of crisis, then the patient may need to be admitted to hospital for a brief crisis admission until that crisis has passed, as a part of containing the suicide risk. Admissions for emotionally unstable personality disorder are generally avoided unless there is a real concern about high risk of suicide. It's not all bad news for people with personality disorder, though, and there is hope. So personality disorder can change over time, and symptoms of impulsivity and self-harm may improve with age. So lots of people think that those with personality disorder will never improve, and that's simply not true. There is evidence that particular personality traits can improve slowly with age, with self-growth and self-knowledge and life experience, and people can learn to self-regulate their emotions in a better way and learn better coping strategies to reduce that impulsiveness and those self-harm tendencies. So there's definitely a reason to give people with EUPD hope that things can improve, and there is evidence supporting psychological treatments as well. So final points, a few key messages to remember are that those with personality disorder can also experience other comorbid mental health conditions. Comorbidity in mental health generally is very common, And those with emotionally unstable personality disorder or any other personality disorder may also suffer from depression at times in their lives, or substance misuse issues, or other mental health problems like eating disorders. And many professionals do this thing called diagnostic overshadowing. And that's when we put all the symptoms down to the personality disorder. So we need to be wary of that. And many patients with personality disorder do self-harm during their lifetime. And as mentioned in the previous slide, it's important to take all of these self-harm attempts seriously and explore the risk of further self-harm and the suicide risk during times of crisis. Unfortunately, a significant proportion of patients with emotionally unstable personality disorder do actually go on to end their lives by suicide. Sometimes it's inadvertently, so due to the risky behavior and impulsivity during a crisis. And sometimes it is intentionally. And that could be because life is just so difficult and intolerable for the person. They feel they have no other escape but to end their life by suicide. It's thought that perhaps 5 to 10% of people with emotionally unstable personality disorder do end their lives by suicide over the course of their lifetime. In the next session, we're going to learn about the importance of validation for patients with EUPD, and that's one of the best things you can offer your patient when they're in distress. Thank you for listening, and if you found this video helpful, please like and subscribe and check out the other resources on my channel.